my name is Chris Bono, and I'm a spine surgeon in Boston, Massachusetts, at Massachusetts General Hospital, and very happy to be asked to give you this talk about the management of unstable thoracolumbar traumatic injuries. And since we're talking about traumatic, as a spine surgeon, sometimes it feels like everything that we do is traumatic, especially if you have a practice like mine with a lot of revision spine cases. Beyond that mental trauma, I want to make sure that we make a distinction here that we're not talking about compression fractures in the elderly. I believe you have a separate talk about that. And this is not high energy trauma. This is more of what we're talking about, which includes high energy trauma that creates fractures and dislocations of the spine that are clearly unstable. What's the key difference or the key component that makes things unstable? It's the energy that is imparted, the energy that's delivered to the spine from the injury. So we are really talking about the high energy mechanisms such as car accidents, motor vehicle accidents, falls from height. It's oftentimes sporting injuries. And then as far as violence such as gunshots and stabbings, although they're common, these have a very different mechanism of injury and will not be the focus of today. The big question is, how do we treat these high energy injuries, and do they all need surgery? In spine, I really don't like the term need, because most of the time we're talking about what would benefit from surgery. And in this case, I don't want us to be too knife happy, too quick to offer surgery all the time. In order to make these decisions, we have to understand some basic concepts and principles. And these are of stability or instability. So what makes a spine injury unstable? What is the patient's neurologic status and whether or not they have compromise? And then ultimately realigning the spine when it needs to be realigned. In terms of stability, one thing that we have to understand is the neutral zone of the spine. And that's what I'm attempting to show in this picture, where we have the spine without any muscles, without any neurologic structures, just the bone, the disc, and the ligaments. And there's an inherent amount of movement back and forth of the spine that is then restricted by the discs and the ligaments. That is the neutral zone. So if we were able to magically take the spine out of the body and just hold it by the sacrum, where would it flop back and where would it flop forwards? It bends, but it stays together. When we have an injury mechanism, some of those structures can be disrupted. It can be circumferential, it can be just of the posterior ligaments, it could be just of the anterior ligaments. And with those forces, if we took that same spine and held it by the sacrum and we flopped it forward and flopped it back, something is going to misalign and it's going to fall off. If we have a patient that is injured and we try to get them up with physical therapy to stand, but they have an unstable spine, the spine will fall apart. So what are the keys to stability and the keys to assessing stability? Well, when it's clearly a bad injury, stability is not a question. It's unstable. We see misalignment, and we already know that with that amount of misalignment, that the ligaments cannot be intact. The keys are not the bones. We can have fractures of the bones. We can have compression of the vertebral bodies. We can have burst fractures of the vertebral body. and still have a stable spine. It's once those ligaments are disrupted, particularly the posterior ligamentous complex, that's when the spine becomes unstable. It would be rare, but we can have a spine that has no fractures and has complete circumferential ligamentous disruption that would be highly, highly unstable. Instability is not always that obvious. We have here a CT of a 36-year-old man who was involved in a motor vehicle accident and is neurologically intact. And what we can see is there's a vertebral body fracture, and this looks like a burst type fracture in which the posterior aspect of the vertebral body is a separate fragment. It's protruding into the canal. And we also see this subtle fracture of the lamina. Now, I will, number one, say that I am a strong proponent of the two-column theory of stability, not the three-column stability theory by Dennis. We'll talk about that a little bit later. Just by having this little lamina fracture on the back does not mean that this is an unstable injury. In fact, what we have right here is a relatively well-aligned spine that we need to determine the integrity of the posterior ligaments. How do we do that? Well, we get a follow-up study using an MRI. We can see if there is discontinuity, a disruption of the posterior ligaments. And here we do see this where the interspinous ligaments and the supraspinous ligaments look like they are disrupted. And that's just the continuation into the lamina fracture that we see. It might have been possible to get that lamina fracture by compression and not have those ligamentous injuries, and that would have been a stable fracture. So I will beat on the three-column injury theory by Dennis just a little bit more. And the reason I want to talk about this is when Dennis developed the three-column theory, which the anterior column is the anterior 2/3 of the vertebral body and the disc, and the posterior 1/3 is of the vertebral body and the disc is the middle column, and then the posterior column is the ligaments and this and everything else from the pedicles on back. It was based on a couple of cases in which patients who had burst fractures had a neurologic decline when being treated non-operatively. And the proposal was that the key to stability was the middle column, and that if you had 2 out of 3 columns that were disrupted, then that was an unstable injury. The problem with that is every burst fracture, therefore, by definition, is unstable. We know that not to be true from the randomized controlled trials of burst fractures being treated non-operatively versus operatively, and many other studies that show that burst fractures can be treated successfully non-operatively. That's why I and many others have migrated back to a much older theory, which is the two-column theory proposed by Holdsworth back in 1962, which really has highlighted the importance of the posterior ligamentous complex, as we see on this MRI. So we've got the vertebral body and the discs, the whole thing being the anterior column, and then the posterior column is the PLC and the bony structures. What's become a more attractive way to present this is not even just talking about the posterior ligamentous complex, but the posterior tension band, so that it may be a combination of both bone and ligament that disrupts the ability of the posterior column to resist any type of tensile forces. So again, we've got unstable burst fractures and stable burst fractures. And the difference between the two is not always so obvious. And this is one case that I've chosen to operate on because we were highly suspicious of a disruption posteriorly. The next principle is realignment. So the first thing to understand is that it doesn't have to be perfect. We don't have to get perfect alignment. What we're looking for is overall global balance. Now, we see some very alarming pictures here of a patient that I treated many years ago. She was 17 at the time, was involved in a bad car accident, but was miraculously still neurologically intact. We see the injury here, which has gross translation on the coronal views and misalignment on the sagittal views. We know that it's unstable, miraculously neurologically intact. And even if we were going to say, well, let's just treat her non-operatively and just take a chance on this healing, this is not an acceptable alignment. And of course, we would not treat this non-operatively because it's obviously unstable. So looking at all of our different principles, is it unstable? Yes. Is it misaligned? Yes. Does it need surgery? Yes. But the real problem here, or the danger here, is that she is neurologically intact. So we have to balance how much we're going to manipulate to realign with, we don't want to disrupt her neurologic status, which is intact. So this is a case where we put some multi-level fixation above, multi-level fixation below. We use neuromonitoring, and we very gently distract until we get some realignment. Is she 100% perfectly realigned? Maybe not. You know, could we have introduced a little bit straighter or more lordosis, or is there still a little bit of a coronal deformity? I would say maybe just a little bit, but with the distraction, this is where it's settled back into a generally anatomically normal position. And I really make a decision not to push it beyond that anymore. So the real key is enough, but not too much. Sometimes realignment leads to decompression. So this is actually, these are images of that patient, and we see why she was still neurologically intact. Is she actually had a pedicle fracture on one side, so that when she had this rotational translation injury, it didn't cause canal compromise. But ordinarily, we've got a rotation or translation, and we've got these two rings. I like to call them napkin rings, that when they are misaligned, they're going to cause canal compromise. Purely by realigning them, we are decompressing the canal. And that's more often the case when we're looking at cervical facet dislocations. We do an immediate reduction, and we are effecting decompression at that moment. Direct decompression is something that we do often. With burst fractures, we can do a direct decompression, a direct removal of the retropulsed fragments through a corpectomy. That corpectomy can be done anteriorly or posteriorly. It's rare that we would just do a laminectomy for a fracture of the vertebral body because it doesn't really decompress the canal very well. If we were doing an anterior approach, we'll maybe do an anterior retroperitoneal approach. The fragments are removed in piecemeal. They can actually be saved and salvaged. And by doing that, they can be placed inside of a cage to reconstruct the anterior column. And then there can be some type of fixation, whether anterior or posterior. Now, we want to put these principles in action so that we can determine which fractures need surgery, which fractures are unstable, and how do we think about those that are on a, let's say, the borderline between stable and unstable. So we've got these generic terms, these general injury types that we're going to talk about. Compression fractures, even though they're like the osteoporotic fractures, we're not going to talk about osteoporotic fractures. Burst fractures, seatbelt injuries, also known as flexion-distraction injuries, and fracture dislocations. Now, everyone would agree that a compression fracture is generally stable because the PLC is intact. And we treat them non-operatively with observation and mobilization, and most of the time without a brace. Well, that is true unless there is ligamentous injury posteriorly. And that's when a compression fracture is no longer a compression fracture and actually becomes a flexion-distraction injury, which we'll see in a little bit. But then we're talking about doing some type of posterior fixation. Burst fractures are the most common. They're also the most controversial particularly in a neurologically intact patient, because there are so many people that have been trained in different ways. There's a preponderance of literature looking at different treatment methods and whether you should treat them operatively, non-operatively, and in which way operatively. So what are all these controversies? So first off, some say to fix them all. Well, I was a fellow in 2001 to 2002, and I was trained to fix all burst fractures. They were all operative. Again, because I was trained to use this Dennis classification. That's clearly not the case anymore. The other controversies is if you're going to take them to surgery, do you go anterior or posterior? If you're going to go posterior, do you fuse them long or do you fuse them short? And do you fuse them at all? And if you go anterior, do you need to also do posterior fixation as well? Fortunately, we have some really good high-level evidence. This was first presented by Dr. Kirk Wood, a good friend of mine who used to work here at Mass General. And this is a classic article now from JBJS in 2004, which was a randomized controlled trial looking at surgery versus non-operative treatment for stable burst fractures. So these were patients in which any type of posterior ligamentous complex disruption was thought to not be present. They were thought to have intact PLC. And this study found no difference at 2 years. What's important is to look at even the degree of kyphosis of the patients treated in this study. Sometimes it was pretty high. It was maybe even 30 degrees of kyphosis, and they were still successfully treated non-operatively. In a 20-year follow-up of this study, worse outcomes were actually found with surgical patients. They ended up having more pain and more other issues than the non-operatively treated patients. There are some weaknesses of that study with attrition, and we can debate that at another time. But if anything, this was definitely not showing that we were missing something at the 2-year mark. What is not controversial? If you have a burst fracture and someone has a neurological deficit with or without a posterior ligamentous complex disruption, they're getting an operation. And that operation can be either posterior or it can be anterior. With posterior, you can effect some type of decompression by realigning and distraction, particularly if that is done within the first 48 hours after surgery. If anterior surgery is being done, again, we saw how that is directly decompressed with a corpectomy. There are also posterolateral corpectomies that can be performed to do the same thing as an anterior corpectomy. Back to the controversy, what is the ideal surgical approach? Again, there's really not any literature demonstrating one is superior to the others. Some studies have suggested that anteriorly is better, some that posterior is better. Part of Dr. Wood's study was a randomized, within that randomized controlled trial for neurologically intact patients, both anterior and posterior surgery was being randomized, and he found no difference in those two groups either. Some people choose to do an anterior and posterior if there is some ligamentous injury posteriorly, even if they've done a corpectomy. There's controversy and discussion about how long the construct should be. The proponents of a short segment construct say that they want to save motion segments. Those who propose a more long construct, which is 2 above and 2 below, state that they really just don't want the construct to fail. And we certainly have seen studies that have shown a high failure rate with short constructs. A short construct classically is a screw above and a screw below without a screw into the fractured segment. The problem is when there's a lot of comminution of the vertebral body and there's a lot of height loss, there's not anterior column support, and those patients can develop screw breakage, recurrence of kyphosis, and can have instrumentation failure and pain afterwards. The long construct is 2 above and 2 below. That is a more stable construct for those who appear to have too much comminution of the vertebral body. And what's come about more recently is doing a short construct, but placing a screw into the injured level, both biomechanically in vitro and also clinically. That has been demonstrated to be a nice alternative if you can get that screw in place. Technically, that can be difficult sometimes because the pedicle is mobile and you may not be able to get a screw into that segment very well. We're moving on to another injury that is usually unstable, or by definition unstable, and that's a seatbelt injury, or also known as a flexion-distraction injury. As I mentioned previously, it can be considered an unstable compression fracture. Now, some of you may be saying, well, a flexion-distraction mechanism should not produce any compression of the vertebral body. Well, if we had a perfect classic seatbelt injury where the fulcrum was way out here from a lap belt, no, we may not have any compression of the vertebral body, and we have only distraction of vertebral body and all the posterior elements. But that's not usually the case. What's more common is that there's some compression of the vertebral body. The fulcrum is somewhere within the vertebral body, so we have compressive forces anteriorly and distraction forces posteriorly. And this is a good example here of a seatbelt type injury that can be unstable, but can also be fixed with a short segment construct because we don't really have any comminution of the vertebral body. Oftentimes, if the pedicle is not necessarily involved, it can even be a single motion segment, meaning screw at only 2 levels, 2 adjacent levels, and you can really fuse as short as possible. Fracture dislocations are the easiest to make a decision about, but unfortunately are the most devastating. They're uncommon. They usually have a neurologic deficit. They all get fixed. And by and large, these are patients that are treated with a posterior construct and a long posterior construct. Here, if a patient has a neurologic deficit, we are trying to stabilize. We're trying to realign. By realigning, we're decompressing, but we do not want to sacrifice any type of stability after the injury has been fixed. So we do end up fixing them and with a long construct, such as this one shown previously, 3 levels above and below. So the take-home points here are to stick to principles. If a patient has a deficit, they're usually going to have surgery. If the patient has translation on their images, they are clearly unstable, they're going to get an operation. If you believe that there's a posterior ligamentous complex injury or a posterior tension band injury, they're going to have surgery. And when you take these patients to surgery, you need to keep the principles in mind to realign, decompress, and stabilize. Thank you very much for your attention, and I hope that at some point we can all see each other in person. I understand that this is the next best thing, which is a virtual platform, but I do wish you all luck.